So my talk today is really starting on the basics and some of my ideas on the future of skull-base surgery. So first question, is there any future? Because actually we know that many young neurosurgeons say that it's better to treat everything by cyberknife or whatsoever, radiosurgery. So still in nowadays, skull-base surgery is staying a challenging surgery, and there are some principles. First of all, we have to understand the surgical anatomy. We removed obstructive bone and we avoid any brain retraction. We use magnification microscopes, and more there is an important role in endoscope. We use microsurgical techniques by sharp dissection, preserve and especially reconstruct vascular supply and cranial nerves, and reconstruct the surgical field. So remember, and take-home message is that this remains a stepwise surgery. And it is important to point out that anatomy-based microsurgery and the development of skull-based techniques have led not only to a greater understanding of these lesions, but also to increasingly improved outcomes. What do we need is to have accurate clinical and radiological investigations, which is essential to draw the surgical plan. The best results, basically spoken, we have and obtained by the best knowledge of anatomy, the best surgical tools, the best surgical skills, and for this cadaver hands-on courses are very useful, and the best strategy by surgical planning to make a choice to the best surgical approach. But what about a wait-and-see behavior in case of no or slow-growing tumors? What about two-step surgery and endoscopic surgery? What about radiosurgery? And what about the role of vascular reconstruction and bypass surgery? There must be only one goal, and this is the surgical resection must be the avoidance of permanent neurological dysfunction and morbidities with the maximum of tumor removal. So the most important factors towards this resection depend, of course, of the nature and the extension and the symptoms of the tumor, the involvement of cavernous sinus and vertebrobasilar system, and last but not least, patient's age condition. What is essential for a skull-base surgeon? He must be able to work for long hours under a microscope. It means he needs a good physical condition. He needs a high degree of technical competence, and patients encouraged to successfully tackle the problems that are likely to be encountered. We need special requirements and an important role for anesthetic management to maintain perioperative hemodynamic stability, reduce the intracranial pressure, protect the brain in the event of vascular occlusion, and allow neurophysiological monitoring of cranial nerve and brain functions. In case of surgical exposure, it helps in reducing the operating distance of the deep lesion from the surgeon and reduce in the same time the need for brain retraction. So what is important? To have an easy sitting or standing position for hours. How do we evaluate the skull-base pathology? There are two primary issues. We have to identify the pathology, and we have to precise the extent and location of the pathology. For this, we need carefully performed and analyzed imaging, which can fairly precisely define the location and the extent of skull-base lesions pre-op, and the relation of skull-base lesion to vascular structures, particularly the carotid artery and the jugular vein are often a problem. So a cornerstone of the therapeutic decision-making progress is the pre-treatment evaluation of risk of temporary and or permanent internal carotid artery or vertebral artery occlusion. We know all these many different skull-base approaches which you can find in textbook. So about the past, we know all our great pioneers, and many of them are here, and we are thankful. And we know also the present where we are. So what about the future? Let's start the future by I want to show you some of my cases. So this young lady had a plantar sphenoidal meningioma with a hemorrhage, as you can see here. This one, young lady, and there was a hypervascularized dura, as you can see, into the planum, and there was hyperostosis. So I decided to do this and remove this by a bifrontal transvasal approach, and you see MRI 7 years after the surgery with a good result, and patient doing well. And what about this case of meningioma? You see there is some involvement also in the cavernous sinus, and a huge anterior process, which you can see here on these slides. So, should I be very aggressive and perform orbitozygomatic approach or a simple pterional approach? I make a decision to make orbitozygomatic large approach. You see here the orbit, the eyeball, you see extradural space, optic nerve extradural, and the intradural site, and a total removal of the dura, of the tumor, including the cavernous sinus part and the postoperative result. Patient did very well, no morbidities. This man, 77 years old, has a left side meningioma, occluding partially the middle cerebral artery, and he had a motor speech temporary arrests. So I decided to do just a pterional approach and remove part of this tumor, and leaving part of the tumor inside the carotid, inside the cavernous sinus that you can see here. And this patient doing well, has no speech arrests anymore, and has no morbidities. This young man was followed in another university hospital for 8 years with a low-grade sarcoma, chondrosarcoma, and you see the tumor. So I was deciding to do it 2 steps, and I first did an orbitozygomatic craniotomy and an angiopetosectomy and removed the tumor. As you can see, this is a post-op CT scan, and you see the patient after surgery. He was unable to walk before surgery, and after surgery he did very well. The post-op result showed still some remaining part of the tumor, which was very, really compressing the brainstem, but the patient was doing well. And even MRI, some years after, about 9 years after surgery, showed exactly the same remaining part, and not expanding anymore since then. Another lady presenting a low-grade chondrosarcoma, as you can see here. This one, I decided to do pterional craniotomy and remove this tumor, as you can see here, by extradural view, in between the orbital fissure and the trigeminal second branch, and remove the tumor with the immediately post-op result on CT scan, and about 6 to 8 months after surgery, a good post-op result, and the lady is still doing well till today. Another case is this 58 years lady with deafness and gait disturbances, and she had a very huge meningioma, as you can see, and I was drawing my surgical plan to do 2-step surgery, and first by a simple suboccipital craniotomy, remove this part of the tumor, and then by subtemporal approach to try to remove the second part of the tumor. So I did it 2 stages, and that's the post-op result. This was very good and a happy lady, and also the surgeon was very happy because this was a really hard tumor to remove, but in 2 steps was much easier. You can see here the result. This is a foramen magnum tumor, as you can see, jugular tubercle meningioma, which was performed in a 4-lateral approach with a good result. Another meningioma, large petroclival meningioma, is a young lady as you can see here, at the left side, which was performed in a 1-stage classical combined petrocell approach with a good result, and some remaining part of the tumor, but no brainstem compression anymore, but some small remaining part of the tumor, but we can follow these patients for the near future. And this, last but not least, is a giant cell tumor of the dens, which we remove transorally by an open way, no endoscopically, because I'm not a skillful endoscopic surgeon. So, and we've had to fix for stability posteriorly. So this is the post-op result, and the patient did well. So after so many years and getting older and now retired, I put my questions, my honest question to myself. Was or is surgery the only option for these patients? Or have I been too aggressive in some of my surgeries and or approaches? My answer to myself, surgery was yes, the only option. But getting more experience, I do realize that in some cases I was really too aggressive and I did not need these large approaches. And this is just by experience. So this is why I'm telling you that we as older surgeons have to teach our youngsters to better approaches and to have good decision making before starting the surgery. So my idea, or our idea about the future of non-surgical way is we need in the future contemporary anesthetic techniques and more improvements. We need better interventional neuroradiology, maybe also in the hands of neurosurgeons. We need more and important electrophysiological monitoring, surgical instrumentations improvement like OmniGuide laser, Doppler and others. There is a very great impact of the neuroimaging for the future, many ways to look inside the skull, and of course there is still space for advances in perioperative care, ICU and neurointensivists. And not on a surgical way. I think we have to go for less or minimal invasive techniques. There is an important role for the 3D endoscope and endoscopic assisted surgery. There is for sure a role for two-step surgery and for vascular reconstruction and bypass surgery. So we have to pay attention to all this, and also for surgery followed by radiosurgery. I got this slide by Dr. Fukushima by illustrating some of these skull-based bypasses, and I present this because as far as I think that we have to force younger neurosurgeons to train very well in the future on reconstruction and bypass surgery. If I was still a young surgeon, neurosurgeon, I should go for this, and also for endoscope. So for the future, I think it's also good to have some combination and teaming with not only with the neurosurgeons, but ENT surgeons and head and neck surgery. With one goal, avoid any morbidities and making life comfortable to our patients. And last but not least, which was told by Professor Emil Boos to me, maybe the future is knowledge about the genetics of tumors. Thank you so much. I had my heroes in my life, I had my mentors, and I had my friends, all of you. Thank you so much.